both of these, so either one of these are fun. So we got everybody back? All right, so now we're gonna move into atrial issues that you're gonna see pretty often. A flutter is a rhythm. You will hear some doctors call it, instead of calling it all P waves, you'll hear them call it an F wave. Don't worry about that. For our purposes, these are all P waves here. These two extra ones are both P waves. Now notice it looks a little different than the one right next to the QRS, but very similar, right? So a flutter can happen for a variety of reasons. Some people feel it, other people do not feel it. If you feel it, it's what's happening is the atrium is contracting. In this case, there's two P waves, right? It's contracting twice before the ventricle does. So the ventricle's losing that atrial kick, right? It's not getting as much out of that atrial kick as it should. And that is coming from the atrium, and you know that because what's affected is the P waves, right? So that's how you know atrial flutter. The other way to know atrial flutter is if you look there, some people will call that a sawtooth pattern, like if you just look in between here. Not everybody knows what a sawtooth looks like. This looks like an alligator's back or a dinosaur's back. That's how you know it's flutter, right? The other way you know it's flutter is it's generally very regular. Like look at your R waves, they are evenly spaced. See that? So with flutter, it's usually evenly spaced. You definitely have a repeating pattern. This is what we would call 2-to-1 conduction. You can see 4-to-1 conduction, right? This is coming from the atrium. Generally, I say this as a general rule, generally the extra impulses are coming from the pulmonary vein, right? And that's what's happening. It's not being generated from the SA node. It's getting generated from another location. And so the atrium are responding and they shouldn't, okay? So that's what we mean by P waves present and F waves, because this is a P and this is an F. You don't need to worry about it. For our purposes, we're gonna say, oh, there's 2 P waves for every QRS. So things that may cause this: rheumatic heart disease, meaning they had rheumatic fever as a child, right? And this will show up later in life because the leaflets get damaged on the valves, and we'll get into all that later. Ischemic heart disease, so people who have heart disease where they're not getting good blood flow to the heart muscle can have this. Alcoholism, hyperthyroidism, we see this a lot. And they're generally, it depends how fast the atrium is going as to whether they're symptomatic or not.
Did you say hypo or hyper?
Hyperthyroidism. And when you get to Karen here in a few weeks, she's going to talk about, what the thyroid can do to the heart. All right, and the #1 dysrhythmia in the world.
For a flutter rhythm, can it also be irregular too?
Not generally. Generally, you'll see boom, boom, then the QRS, or boom, 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 QRS. But you can get to where it's trying to convert, so you'll get it regular, and then you'll see, like, for lack of a better word, it lengthen out like a pause of a few seconds. Yeah, it can definitely do that. But generally, what you're going to see is this consistent pattern in between. So yes, you are right, it can. And that's your heart trying to convert itself back to a normal rhythm. All right, so this one, you guys gotta really, really pay attention. This is the #1 dysrhythmia in the world. It is growing every single day. We're not sure why. We think the biggest reason is people are living longer, right? So as the heart ages, it tends to start responding and doing its own thing. So these patients generally are very symptomatic. As you can see, this is chaos, right? If you look at that EKG, this is just absolute chaos, right? And it's because the atrium up here are firing off all these extra electrical impulses. Generally, it starts from the pulmonary vein, but can progress, and AFib is a progressive disease. So I'll just tell you a little bit of my story. I was first diagnosed with AFib almost 10 years ago to the day. I went in to get a kidney stone, and I went in AFib on them. No history of it, right? And as time goes on, they've had to up my medication, right, to keep me out of it. So it is a progressive disease, so you need to know that. So, you know, there's a lot of debate on how to treat it. A lot of docs, depending if you're younger, are going to try to treat it with medication for as long as they can, right? Nowadays, we see pulse field ablation coming into play as a first-line therapy. And there's been some pretty good outcomes, especially with A-flutter. AFib is quickly catching up there as well. But what you can tell here is there's no definitive P wave anywhere, right? These are more than likely T waves. And so you see, what you see is this, the atrium are not squeezing, they're fibrillating, right? They're just going back and forth like this. And the problem with that is blood is pooling at the top there. What does blood do when it hits itself?
Clots.
It clots. And if you get a clot and you throw it to the brain, we have a stroke. So these patients are 5 times more likely to have a stroke, right? So this is not a rhythm we want them in. Where flutter, we may just treat the symptoms and go, okay, we're gonna, if it starts to become symptomatic, we might go in and do an ablation. Ablation is highly successful against flutter. Not as, although it's pretty good with AFib. The other way you can tell AFib, if you're not sure, is it's regularly irregular. So if you look at these 4, and you measure those R's, they're pretty close to one another, right? But notice here, notice how it got longer, and it gets longer, and it gets longer, now it goes short again. You can find regular patterns, but it's an irregular heartbeat. Does that make sense? That's the other way to tell it. If you're not sure, if you go, wow, that might be a P wave and the atrium's just been damaged, but I'm not really sure, look at your R's. If they're irregular, when you measure them, it's AFib. Remember, in flutter, they're gonna measure pretty darn close every time, okay? So, I don't wanna miss any of this, so let me go through this because I get all, excited about this stuff, right? So it affects approximately 6.2 million Americans every year. In patients with AFib, the SA node is no longer initiating the impulse. And that's what I'm trying to show you with these little stars here. These impulses are coming from all over the place now, right? And then it's generated outside the SA node, generated by the pulmonary vein in the left atrium. As a result, we have this disorganized function of the atrium. We get the pooling of the blood, and then it puts them at a higher risk for stroke. And cardiac output is decreased by about 20%, right? Because what are we losing? The atrial kick, okay? So it's important you know this because those of you working in ER, I bet you see AFib over any other dysrhythmia. Would you agree or disagree? Those of you, and it's growing. It is growing. So we're going to talk about that. So this is probably an old statistic, 70,000 ER visits a year in the United States. It's a pretty high number. So are we good on AFib? I'm going to talk some more about it here. So again, like I said, about 6.1 million Americans in the US. Apical pulse is irregular. We're losing 20% of our perfusion. It's the anxiety of it. You feel it, you know it, and you're like, oh boy, you're worried about having a stroke, you're worried about driving, it's difficult to walk. So you have to address the psychosocial part. I know you guys came from psych, so they've covered all that. So what causes it? Well, we're not 100% sure, right? There seems to be a lot of risk factors, which are the typical ones: hypertension, obesity, hyperthyroidism, alcohol, holiday heart. we see the most emissions on 2 holidays in the US. Can you guess which 2?
Is today one of them?
Oh, no, actually it isn't.
Christmas.
It's called Holiday Heart.
Christmas, Thanksgiving.
New Year's Eve, New Year's Day, right? 4th of July.
Really? 4th of July? Fireworks?
Yeah, it's called Holiday Heart. They usually come in because they thought it was just a hangover. Now they can't catch their breath, they're lightheaded, they're fatigued, right? And we do know it follows a genetic link. Is it always follow a genetic link? No, we know that in some families it does. Like in my family, I didn't know this, but my grandfather had it, had a stroke, passed away, never met him. My dad ended up having it and having a stroke. And then my sister had it, and now me. So definitely can follow a genetic link. So it's not always because of hypertension, obesity, and sleep apnea. But those things can exacerbate it, make it worse, right? The problem is long-standing. If you let this go and you don't try to fix it, the atrium muscle will remodel, and that becomes its norm. And so now we've permanently lost that atrial kick. This is why we don't want them to stay in AFib. We want to get them out of it as soon as we can, and we're going to try, you're going to see, we're going to try medications, rate control, rhythm control, ablation, keep them out of it, because if this remodeling happens, that becomes the new norm, right? And we don't want that to happen. Other things that can cause it, nursing school. All right, so there's multiple causes here. Again, these are not rhythms we want people to stay in long term. So the treatment of AFib and A-flutter, you'll get into the big, huge debate between, we'll be working here shortly. Cardiologists, there's like 2 fields. One believes control the rate, the other one believes control the rhythm. Newer docs, younger docs are like, why aren't we doing both? And so the younger cardiologists tend to do both. They will give a rate controller like a beta blocker, they'll give a rhythm controller like flecainide, amiodarone, right? And they'll try to do both. Keep it in a normal rhythm, keep the rate low for as long as they can. If medication, so that's the chemical, if medication doesn't work, cardioversion, and I imagine some of you in the ER have seen cardioversion done, right? Where the meds don't work. And then catheter ablation. Now, I'm a member of the American College of Cardiology, and there's big debate here to move this up. Move it up to #1. And there's a big, huge study going on called the TRIUMPH study. And I wouldn't be surprised in a couple of years when that study is published that catheter ablation doesn't move up quite a bit in the course of treatment. They've had good success. People, you know, A-flutter, it's like 85 to 90% successful in flutter, and AFib, it's about 70 to 80% successful. So they're seeing good success rates. So chances are when they start seeing success rates that high, they move that up. So let's talk about rate control. So things we're going to use for rate control. First line are your beta blockers, especially your metoprolol. Metoprolol comes in 2 varieties. Metoprolol succinate is a once a day, 24-hour med. Metoprolol tartrate is every 12 hours. Again, debate among cardiologists, some want a higher level in your bloodstream consistently. They don't want the drop, so they'll go with the titrate. Others are like, no, I'm good with the once a day because I get better compliance. So it just depends on the cardiologist. Both are good meds, but you need to know which one you're getting, right? Bistolic is a new one that isn't up here. That works really well. So generally we go with a beta blocker first, calcium channel blocker second. We reserve, yes?
Sorry, you said succinate and what else?
Titrate.
And that's 12 hour?
Tartrate. Tartrate is 12 hours, and succinate is 24 hours. calcium channel blockers we generally reserve. Our ER people can verify this. Generally what happens in the ER, you come in AFib, we're gonna give you a bolus of cardizem, or I'll put you on a cardizem drip and see if you convert, right? That's why we kind of reserve ditilizum, because that's the one drug that has shown to help convert people out of this. Does it work 100%? No, I don't think any drug works 100%. But this is why we kind of reserve this one and don't just prescribe it every day. Dig has fallen a long ways. It's going to fall even further because of dig toxicity. It has a very narrow range, and we don't have that worry with beta blockers or calcium channel blockers. And then amiodarone. We like amiodarone a lot. The problem with amiodarone, it can cause swelling, especially lower edema swelling. So, and we have to start out at a high dose of 400 twice a day. Then we'll bring it down to 200 twice a day. But a lot of people can't tolerate it. So here's our cardizem. So you can see what it does. You can see the action. It's a calcium channel blocker, so it's going to slow cardiac conduction, right? It's going to try to help you get back into a normal rhythm. It works. It's fairly successful with AFib, A-flutter, and SVT. It works pretty well on AFib from what I've seen. Usually given a bolus followed by a drip will do it. So you want to monitor their vital signs. You're going to stop if they become hypotensive, bradycardic, or if they go into CHF. But it does work well. So then we got this guy. Who in the hell is Chad Stu and his friends Chad Stu Vass Stu? Why does it matter? You're required to chart this. This tells us with your AFibbers what their chances are of throwing a blood clot, right? So as Nurs says, it's a tool in your toolbox, in your EMRs. Just go to this tool, you put in their risk, like age, did they smoke, do they have hypertension, right? It gives you a number and it tells you what the risk factor is. It matters because you have to chart it, right? Because we use this to calculate stroke risk. The American College of Cardiology has a new app out that's pretty easy to use. It's a little easier than that one to use, but right now that's what Jacob recommends. So we want to prevent a stroke, so we want to prevent a blood clot, right? So if we give warfarin, this should be a review, right? We're sending them home on warfarin. It should, the INR should be between 2 and 3, right? We've talked about this before. I know it's a while. Antidote is vitamin K. Heparin or Lovenox, 2 to 3 times normal, right? So generally somewhere around 50 to 65-ish. And the antidote is protein sulfate. And then we don't use the Bigatran much anymore in this country. It's still used over in Europe. We've really gone to Xarelto and Eliquis, apixaban. And those guys given once a day. There's no routine blood work. I'm sorry, Eliquis is twice a day. Xarelto is once a day. There's no routine blood work. There's nothing wrong with the Bigatran. It's just these two have been proven far more effective. And so, actually, the Bigatran is Pradaxa came out first before those two, and it's a prothrombin inhibitor. It worked well, but these guys work even better. So that's rate control. Questions? I know this stuff gets a little, and we'll talk it through.
Just off topic question, do you only shock for VTAC and VFib, and that's it?
Well, you can shock for other things, like if you have to cardiovert someone because they're in AFib and cardizem failed, you can't leave them in AFib, or you don't really want to. So you can cardiovert them. Generally, you're going to take them down to, I mean, you can do it at the bedside, but generally it's more of a planned thing. They're going to take you down to generally the cath lab or some sort of procedure area. They'll have a crash cart available, right? You're generally out, although I've seen a few lately just kind of put them into twilight. and they'll take the pads, generally most cardiologists generally at the lower setting, right? And they'll time it with the R wave, we're gonna talk about it, and they'll try to get the heart to reset. But that's generally when the chemical cardioversion has failed. Meaning they've given you cardizem or whatever one they pick, and you're not coming out, they don't want you to stay in it. The problem with cardioversion, you might come out for 20 seconds and go right back in. You might be out for 2 days. You might be out for 5 years. There's no guarantee, and so many docs will do it up to 3 times. And then if you don't convert, they'll go, okay, I'm just gonna treat them for AFib, what we call, permanent AFib. And we'll keep them on a thinner. And if it gets bad enough, we can always do a total ablation of the AV node. We'll put a pacer in, right? So that's really physician dependent. I've seen people have 3 or 4 cardioversions before they get to the point where they put in a pacemaker. I've seen other docs, younger docs, usually don't let you stay in AFib. They're gonna say, okay, off to EPS. If EPS can't fix this, then we'll do a total AV nodal ablation, put a pacemaker in. So, and I think it's gonna change even more for you guys because ablation is really shown to work. I mean, when it first come out, not so much, but like anything, they get better at it, they understand what they're doing a little more. Okay, yes?
So at what point would you use a device like a Watchman?
A Watchman is, we're gonna get to the Watchman, but a Watchman is to close that left atrial appendage. And so that is, let's say, I'm 73 years old, and now I'm having all these falls, right? I'm falling, I'm hitting my head. They're gonna take, you get a patient like that, they're going off blood thinners. So we still got AFib, right? We still have a high risk for stroke, so then that left atrial appendage, we're gonna go in there and put a device called a Watchman. It's like an umbrella, basically. And we close off that left atrial appendage to make sure there's no blood clots gonna form there and get into the ventricle. It's a surgical procedure, it works well. There have been a couple of cases where it's come loose, but I mean, that can happen with a stent too. So, pretty rare, but again, they're gonna least invasive to most invasive, right? So, good question. Other questions? Okay. So let's go into rate control. And this is always I would say this is about a 60-40 proposition. Does it work? It works, but it does over time require higher and higher doses. So some of your common meds, flecainide, Ticacin, Rhythmol, are the top ones. Generally, they're gonna be in the hospital when you first start them on this because you have to do what's called serial EKGs because you wanna make sure their QT intervals don't get longer and longer and longer. For most people, that doesn't happen, but it is one of the potential side effects. Amiodarone and Maltac are a choice as well. Maltac was new in about 2017. It shows a lot of promise, but the downside, it tends to put people with AFib into pause. And so for some people it's fine, other people can't tolerate it. Amiodarone, I already told you, causes lower edema swelling. We tend to want to get people off of that quicker. And then way down the line here is DIG, and the problem with DIG, very narrow therapeutic range. They have to come in for routine blood work. So again, we're giving this for quality of life. Remember, all of this is for quality of life, right? We haven't cured the problem. The problem is still there, right? We're just managing it. Does that make sense to you? The AFib and the electrical mess up there is still there. We're just managing it. And at some point, we're gonna have to probably do something more permanent, right? We hope that we don't have to, but I told you, this tends to be progression. All right, so cardioversion is a timed electrical shock. So they're usually sedated, and mostly I've seen them out, right? But recently I've seen them kind of in twilight. So I don't know if that's a new thing or if that person just couldn't, they gave him the normal dose and didn't knock him out, I'm not sure. So what they try to do is they try to time it to the R wave. And they have to be on anticoagulation medication 3 to 4 weeks prior, right? And so a lot of times, how many of you in the ER have you sent home a patient in AFib to get on new anticoagulation? Anybody? He's just nodding his head, yep. Yeah, because most docs don't want to cardiovert them unless they've been anticoagulated for a while, right? Because again, we're worried about that blood clot. So they may send them home, and the patient's like, what do you mean you're sending me home? I feel awful. Well, just being on heparin 24 hours, they're usually not comfortable enough to do it. I've seen it done, but generally they're gonna send them home, bring them back in. So they bring them back in, they sedate them, they'll have the crash cart standing by, right? Generally the defibrillator's on the crash cart, generally, and they'll zap them. And the hope is that they go into a normal rhythm. If they don't, a lot of docs will go to the next level. Some will go right to the highest level and go, okay, I'm not messing around, and they'll try it again, okay? So it's really cardiac physician dependent on how they feel. And remember, one of the things I wrote here, they're always gonna do a trans-esophageal echo, even if you've been anticoagulated for a while. Why are they doing that? And it leads back to where it should go. Somebody asked me the question about the Watchman. What's it go back to? Why are we doing that?
Check for clots before they come out.
Checking for a clot sitting in that left atrial appendage. I saw a really nasty case, probably 8 years ago. That couldn't really see very well in the echo. They decided to go forward. The lady had a clot in that left atrial appendage and it went to her brain. She had a major stroke, right? So they should always do a transesophageal echo where it goes down and sits in the esophagus next to the heart, because they can get a better picture. So that leads us into catheter ablation. So what we're trying to do here is reestablish sinus rhythm, right? This is current practice, and I'm sure, again, this is going to change, but by the time you take the NCLEX, this is still going to be the current practice. Current practice is as the slide says, where treatment has failed to hold it in a normal rhythm, right? Again, it's just like a heart cath. You're gonna go and have an EPS study, right? They're gonna go through the groin. Sometimes they have to go through both sides, depending on, so they'll start with a CAT scan, a 3D CAT scan with contrast, because they wanna see the pulmonary vein, they wanna be able to see areas that are acting up, right? So they're gonna go through the groin, they're gonna bring a wire up, a flexible wire up, and they're gonna look for those areas that are shooting off extra electrical impulses. They're gonna leave the SA node alone, they're gonna leave the AV node alone. They're gonna go over to the pulmonary vein first, because that is most likely the area where this whole thing has gotten generated from, right? Pretty common that it's the pulmonary vein. They go in with, these days, radio frequency. Could be cold, could be, I'm not gonna say hot, warm, just depends on what physician prefers what. They go in there and they create scar tissue. And what they're trying to do is make that signal come in and have to go further around to get through. By the time it gets through, the conduction has happened, patient is no longer symptomatic. They're having great success with it. Like I said, the study is ongoing and they're doing pretty darn good. Best outcomes is performed in an experienced center, right? Fortunately for you guys, you have Henry Ford Heart and Vascular Center right in your backyard. You have Michigan Heart Group and both at Troy and Royal Oak. They are some of the best in the business at it, other than U of M. Those two hospitals are right up there in the country with that. So the hope is that they They don't guarantee it, but they'll tell you what the outcomes are. And they'll say generally what they're seeing right now is it lasts between 10 and 12 years. So I think they're gonna get better and better with it. Let's hope so. One of the things you have to know is it's a long procedure, right? This is not a cardio version. This is not, we're gonna go in and hit one little spot. They're gonna stress the heart. They're gonna try to find these areas that are all shooting up. Because remember what I said about abnormal atrium remodeling, right? Now the atrium is remodeled and is listening to impulses it shouldn't. So they gotta find as many of those as they can, right? So it takes time, right? It takes time to find those areas and take them out. So for A flutter, high success rate. A fib, a pretty good success rate, may need to be repeated. SVT, it's always repeated. They can't, there's only so much tissue they can take out. Okay? All right, so she kind of stole my thunder. So this is your left atrial appendage, right? And this guy is the culprit for strokes. Well, it gets in here, hits against itself, forms a clot, and then if we shock you, it can move down into the left ventricle to the brain, and set up a stroke, right? Always, always, always transesophageal echo before you go in and shock someone. And if they fail blood thinners, doesn't matter which one. Doesn't matter if it's Coumadin, Eliquis, Pradaxa, whatever, right? Pick. Alphabet soup, don't matter. Or if they're falling, the Watchman is the procedure. It looks like a giant umbrella. They put it in here, has a little filter on it, and it's put in with a certain amount of pressure. It works really well for people who fall or have failed, right, blood thinners. Okay, so that's atrial problems. How are you guys feeling? You feeling okay? You're overwhelmed? We need to slow down? Lee's like, I'm overwhelmed.
No, I'm okay. I'm okay.
You sure?
Sure.
Okay. All right. I know it's a lot. That's why I said stick to the big ones. Don't get lost in the minutia. All right, so we're gonna move down now. We've talked about all the stuff in the atrium, right? That can go wrong. Remember, this is a wireless system for the most part, especially in the atrium, right? In the ventricles, it's much more a wired system, right? Because it's coming down here, but if this AV node is trying to respond to all the chaos above it, that's when we get a rapid heart rate. Okay? So let's talk about ventricular escape complexes. This is where the ventricle rate goes slow, right? 15 to 40. Not every impulse is getting through and making it contract is what's going on here. But the ones we want to talk about are these guys. I will tell you this, PVCs will be on the exam, right? So how do you know it's a PVC? Well, look here, you got a P wave, QRS, P wave, QRS, right? Regular, and then look up. This is premature, this is too soon, right? So if you only have one, it's unifocal, right? But if one's going up and one's going down, now it's multifocal, meaning they're coming from different electrical impulses. So what could cause this? Well, alcohol can cause it, excitability can cause it, too much caffeine, your electrolytes being low or high can cause it, right? Treatment usually, if they're not symptomatic, we're gonna give them oxygen, and we're gonna see if it resolves on its own, right? This is not something we have to jump in and fix. Especially if they go, yeah, I kind of feel it misbeat, but I can do my normal activities, I'm not lighted, I'm not shortness of breath. Just leave it. All of us have PVCs from time to time. So these are just some examples. You can see when I'm talking about multifocal, and this might see this on a quiz somewhere. That's multifocal. That's coming from two different places. Right? And then this guy is by Gemini, and how you can tell that, after every regular beat, you have one of these. Regular beat, one of these. Regular beat, one of these. Okay? That one, they're probably gonna be a little symptomatic, like something just seems a little off, right? Okay, so you can look at those. So VTAC. So VTAC here, if you notice, you're not seeing anything but a QRS. Now, many of you would argue and say, oh, that's probably a P, and I would argue and say, well, maybe it's a T, right? I could make that same case that you could, right? This looks like ventricular tachycardia, right? 100 to 250. It's usually very regular, but again, do we want them to stay in this? No, right? Causes, I mean, lots of things could cause this. Drugs can cause it. PVCs, if they're regular enough, can get them going. All sorts of things can make it go into this. So what are we going to do for it? Well, first of all, we'll try to convert them, right? Maybe amiodarone, try to convert them. If that doesn't work, then we're going to cardiovert them, right? And if they become, that's if they're stable. If they become unstable, they pass out, right? Now what are you going to do?
CPR.
You're going to start CPR if needed, right? If not, what's the next thing along the chain of command there? You could do chest compressions, you're going to push drugs, but you're eventually going to try to shock them, right? Cardiovert them. And if they're pulseless, you're definitely going to do the CPR for 2 minutes. You're going to push, what are you going to push? FB, right? All right, V-fib. So again, like AFib, chaotic. There's no real pattern here. It's just, it's because they're quivering. They're doing this. They're not squeezing. They're doing this. This is why you have no real pattern. You can say, well, look at that. That's kind of a pattern. Really? I don't think that's much of a pattern, right? So what are you going to do for V-fib? Shock, right? You're going to do your CPR, your defib, right? You're going to shock, you're going to push your meds, right? But you're not going to wait around. This is not one to wait around for. All right, so your defibrillators these days are usually asynchronous, meaning they will tell you when to shock, right? And they're biphasic. There's not very many monophasic ones around. So it's going, you guys are going, what the hell is he talking about now? Biphasic means it's going to send the electrical impulse in both directions. When they first come out, they were monophasic, which meant it was dependent on how you put the pads on. These days, if you open up a defibrillator, you'll see there's a drawing right on the package, there's a drawing on the pad. It shows you where to put them, but most of them are biphasic. Meaning, even if you screw it up, even in PEDS, the PEDS pads are smaller, even if you screw it up, it's sending shocks in both directions, so you're okay. So we know early defibrillation is the definitive treatment for VTAC, VFib, right? Especially pulseless VFib. What's the survival rate CPR alone? Does anybody know? 3%. Somebody whispered it.
I was guessing 3%.
He's right. CPR alone is only successful in 3% of the time. Think about that. Out of 100 people, 97 would die, right? That's why defibrillators have become everywhere. I mean, you go, I used to say, go to a mall, but go to Myers, go to a grocery store, go to a Walmart. They're in all those places, and that's because it really is the definitive treatment. And these days, they talk to you, they tell you, push harder, push deeper, right? Pick up your rate, too slow, right? Check hand placement, all those kinds of things. They really changed the game. So a little break, I promise Pam I keep this. So if you don't feel like waiting for someone to answer your call, like, I found a great way to get someone in here really quick. Just tap on this lead here, Of course, you should make sure a nurse isn't a new grad. She came in and shocked me, right? So, anyways. All right, couple more, and I think we're gonna stop, because I see the heads doing this. and-
I have a question, again. So, if they're running a code and their IV fails, why do they go into the bone? Why don't they just go into like,
Easy access.
Because it's easy access and boom, you can get that gun going.
oh,
We're not gonna mess around. If somebody's doing compressions and you're trying to fiddle fart with a needle,
okay.
you know, because they're not gonna stop compression. That's the only thing moving blood.
It literally
And it's
takes
pretty
seconds to
steady,
get that
it's pretty,
intraosseous.
like, you don't have to like be like, okay, hang on, you guys are moving, like, you get that leg, you get that gun, boom, you're in.
Yeah, you just can't, you can't
It
take
is,
the
it's
chance
crazy,
because
and it's
there's
like,
so
every time I
much
see it,
going
I'm like,
on.
oh, God, that hurts my leg looking at it, but,
So that helped you since everybody wants to play?
and it's hard to push stuff in it.
All right, asystole. So what are you gonna do for asystole?
CPR.
If it's witnessed, CPR, right? If it's not witnessed, you don't know how long they were down, right?
Are they cold, are they in rigor?
Yeah, right. Then it really becomes an ethical question. If they're cold, do I do anything? Right? It really does, especially if it's not witnessed. All right. So how can you tell this is a paced rhythm?
The spikes.
The spikes, yeah. See the spikes here? So this is 100% pacing. So you may have a patient who's not 100% paced, right? Meaning their underlying rhythm might be good enough at times that the pacemaker doesn't need to make a contract, right? So maybe you see 4 of these and then you don't see them again, right? Until 5 or 6 later, then you see them again. That means their underlying rhythm, we try to keep if their underlying rhythm is strong enough to make the ventricles contract, we try to use that for as long as we can. Because remember, a pacemaker is a generator, right? It's only good for so many years. So if we don't have to use it 100% of the time, we extend its life. So, and yeah, generator changes are pretty straightforward, but still, you're opening somebody back up, you've got them back in the hospital, infection, all sorts of not so good things can happen, right? So, all right, to be a patient, if your patient appears to be an asystole, but is still talking to you, this can mean only one thing, that he's a zombie and you must sever his head from his body before he eats out your brains. Perhaps you should make sure the lead hasn't fallen off. So, am I gonna ask you a ton on pacemakers? No. I will ask 1 or 2 questions. Again, I could spend a whole semester on pacemakers.
What are the questions?
Word for word.
Well, I will tell you it has to do with types. How's that? So that narrows it down, right? So there's temporary, which all of you know your ICD can temporarily pace, right? Put the pads on, put it in pacer mode, we'll pace. Transcutaneous, meaning we got it on the outside of the body, right? In external, we could hook one to your belt. Also, a life vest if we needed to, because we think your heart might stop, so it'll shock you. And of course, the implanted one. The permanent ones, we can do a lot with them. The first wireless one went in, I think about 1.5 years ago at Troy Beaumont. It's completely wireless, sits in this patient's ventricle, and there are no wires. It looks like a giant pill. So they're getting better and better. So ventricle, atrioventricle, biventricular pacing, SICDs, that's one that will pace, but if you go into a lethal rhythm, will charge and deliver a shock. So your care, look, they're gonna go to the cath lab, they're gonna cut a pocket, right? Get next to the breastbone, they're gonna put the pacemaker to ICD in, they're gonna run the wires into the heart to where they want them, depending if they want them in the atrium, they want them in both ventricles, if they want one in the atrium or ventricle, right? They're gonna glue it, they're gonna put stereo strips over it, and they might keep them overnight. So you tell them, your job is to tell them, watch the arm motion for the first couple of months, right? This is not true very much anymore. On Thursday, I got a bunch of pacemakers I'll bring with me. MRI, there's a bunch of them that are MRI compatible now. They're getting smaller and smaller and smaller. And then regular follow-up, even that is becoming a thing of the past. So we can interrogate pacemakers over the phone. They only really have to come in once they're set up and running okay, once a year. The other times we can do it right over the phone. So even that's gotten better. So on the incision, you want to talk to them about signs and symptoms of infection, right? You tell them if the arm bothers them to carry it in a sling for a week or so, not too long, because you don't want that to get all stiff and muscle to atrophy. And I think all of you know how pacemakers work, right? So we send a electrical impulse into the heart, and we can, if it's biventricular, we can make the ventricles move together. If it's in the atrium, we make the atrium and ventricle move together. It just depends on what it is we're trying to do. And again, transcutaneous, external, external. Most of them are going to be implanted up here. We like to go up here. It's generally an area that's pretty safe, doesn't get hit a lot. If I can get Chris to show up, he had open heart, or he had a heart transplant. His was down here in his abdomen. And he'll talk about why that was. Okay. Are you guys up to listening for about 10 more minutes, and I'll let you go. All right, so these slides I changed a little bit because students were getting a little confused. I found some better rhythm strips. So I put these in. I'm not going to ask you block questions on the test. We just don't have enough time to go into the weeds and talk about it. But you need to, especially those of you who work in ER, you need to know what a block looks like, right? And so this is a first degree AV block. Pretty simple. The P wave is way too far away. So her and I are no longer communicating, right? Very well. I'm kind of yelling at her now for her to hear me, okay? See how far away it is? That's a first degree AV block. We don't really do anything with that at this point. We are gonna watch it because that is a signal that things may be coming down the road that we're not gonna like, right? So this is a second degree type 1. So what's happened is now we've progressed to where we have a P wave, we have a QRS, we're still too far away, but now look, we have this eventually it starts close, moves further away, like her and I, we're no longer communicating anymore, right? To the point where I contract and she has no idea, right? She might as well be in the next building. So we have a drop QRS. This is second degree type 1. Again, this is kind of an ominous sign. This is somebody, if you're gonna work like a cardiology clinic, which many nurses do, this is somebody you want back in probably once every 2 months, because if this guy progresses to second degree type 2, now we've got a real issue in terms of perfusion.
It's called a leech back.
Yes. So here's a type 2 block, right? This is second degree, right? Second degree type 1. This is a real person's EKG of it. So again, we're gonna watch it because they're probably asymptomatic. But if we get to this one, which is a second degree, right? Still second degree, but now it's progressed to a type 2. So look what's going on here. Now we have a heartbeat, P wave, nothing. P wave, heartbeat, P wave, heart rate, P wave, heartbeat, and then nothing, right? It's becoming more frequent, right? This is gonna be symptomatic. Here, they're not gonna, they're gonna start getting short of breath. They're losing the atrial kick. Her and I are no longer in constant communication. And if we don't, here's another picture from a real patient. You can see how consistent this one is. Look, it's every other beat is now dropped, right?
Does it become the type 2 when there's another missed one in the 6-second
Yep.
strip?
Yep, it's progressing. It's the same morphology, meaning the same problem, but now it's much more regular. And then finally, and this is why we watch them, especially second degree type 1, second degree type 2, because if we're not careful, her and I are now divorced, right? We don't even live in the same house anymore. She's off doing her thing, I'm off doing my thing, right? So the reason blocks are important is for you guys to recognize that, hey, 2-to-1 AV conduction is not good, 3-to-1, 4-to-1, not good. They may be asymptomatic, or maybe it was a slow progression and it didn't bother them, right? And then here's a picture of a real heart block, right? P waves, no QRSs. And this is what a bundle branch block looks like, right? Remember I told you the Batman or rabbit ears? So that's why these are gonna get second degree type 2, third degree are gonna get you a pacemaker. So there's a little poem, let me catch up with you guys. If the R is far from the P, then you have first degree. Longer, longer, longer drop, then you have Winky Bach. If P's don't go through, then you have Mobitz type 2, right? And if P's don't agree, you have third degree. So Pam came up with her own poem. I think I have it in here. This is hers. I think this was maybe a little personal. Husband comes home, this is first degree. Husband comes home late every night at the same time, but he always comes home. Second degree, type 1. PR intervals get longer and longer until P is dropped. Husband comes home later and later and later until one night he doesn't come home at all. The pattern starts over again, right? We saw that. It kind of resets itself and then marches out, right? Second degree, type 2, Mobitz, right? P wave on time, but randomly drops husband, Husband comes home at the same time every night, but there are some nights he just doesn't come home, right? And then 3, husband and wife are finally divorced but can't afford to move out of their house because of the bad economy. As a result, they are still living under the same roof, but leading 2 separate lives. I want to, just want to sing the Phil Collins song, Separate Lives, right? It appears as if they're still married, but they are not. There's no communication between them. So that was her way of, I think that was a rather personal way. And then PEA, we'll talk about PEA, and then I think we'll name a couple rhythms, and I'll let you go. So PEA, number one thing you guys will fail when you go for your ACLS. So one of the things we make you do is a mega code. And you guys will think you saved the patient, you'll be high-fiving, yeah, we got our ACLS. You gotta check the pulse. The machines can be full. It will look like normal cardiac rhythm. You check the pulse, there is no pulse. Pulseless electrical activity. There's no squeeze, there's no pulse. So you gotta begin CPR. So be aware of PEA, right? Begin CPR, give fluids, give drugs like epi. So that's PEA. So what kind of rhythm is this? Yeah, that was quick. You guys are like, you're Florida. How about this one? So let's work through it. Look at our R's. Are they regular? No. They're regularly irregular. So we have these 3, they look pretty good. Then we have a big gap, and then we have these 2, then a bigger gap, and then these 2 look similar, and then these 3 are closer. Regularly irregular, a fib. And so what is the major complication? Stroke. 5 times more likely to have stroke. Treatment?
Cardiac ablation, pacemaker,
Okay, so let me ask you this way. Treatment in the ER would be cardism, cardioversion if cardism fails. What would be the treatment if they're outpatient? Beta blocker and EPS, right? What about that one?
Asystole.
And what are you gonna do first? Good. How about this guy? Yeah, MI, right, could be going on here. So you just wanna check the patient, check the blood work. How about this guy? Second degree type 2, yep. Very good. How about that one? VTAC, so what are you worried about here?
oh, you gotta check for a pulse.
Pulse, organ damage, brain damage, you gotta get oxygen moving, right? Very good. How about this one?
Yep.
The fib, what are we gonna do?
CPR, shock,
Good. And this one is what kind of rhythm? Yeah, looks good, right? So what does it mean if you don't feel a pulse with this rhythm? PDA, right? It's VTAC, I'm sorry. It's ventricular pace, but it could be PEA if you don't have a pulse with it. Okay, I think we'll stop here instead of going, unless you wanna go through the practice problem.
sure.
All right. We shall do that. So you have a 33-year-old woman with a history of tachycardia, comes to the hospital clinic stating that she doesn't feel well. The nurse connects the client to cardiac monitor, observes a rate of SVT varying between 160 and 180. She reports shortness of breath, palpitations, weakness, appears anxious, blood pressure is 88 over 56. What is your initial action?
Oxygen.
Well, EKG, you got the monitor going, so that's good. What else you wanna do?
Grab the crash car,
Have them do vagal maneuver.
adenosine.
Bear down.
Okay, so let's go back for a minute. All those are right. She reports shortness of breath as number one symptom. Then yes, you're gonna do all the rest, but you're gonna reach up, turn the oxygen on, put it on her nose, and you're gonna do all the rest of those things you said, but that, it's asking you to, you know how this is. What's the first thing you're gonna do, okay? Part 2, later the client is still in SVT, feels much better other than having some palpitations. The heart rate's 150. Which action does the nurse anticipate to be ordered by the healthcare provider?
Swelling.
D, probably, right, adenosine, right? Because we can't leave her at 150. The SVT resolves immediately after IV adenosine is administered because the client has experienced repeated episodes of symptomatic SVT. A cardiologist has been consulted, probably would have been consulted before that part. And treatment options discussed. What is the preferred treatment option? D, ablation. But remember, I told you, you gotta be honest with the patient. Probably gonna take 2 or 3 ablations before it's successful, completely successful. Okay, when working in a clinic setting, which dysrhythmia does the nurse identify as the most common? A, very good. The nurse is caring for a client with an episode of spontaneous VTAC, who has an implanted cardioverter defibrillator placed. What is the priority nursing action? A, yeah, you gotta address that anxiety. It's, right? She's fearful, is probably in discomfort. Good. A client admitted to the tele unit with a new diagnosis of AFib tells the nurse, I feel fine, there's nothing wrong with me. What's the nurse's what response is appropriate by the nurse?
A.
A. Very good. Oh, you guys, I'm amazed. You guys were pretty good. Okay,